neurobehavioral neurology. Why don't you lay the groundwork for what dementia is?
Yeah. So it's a good point, good question. It might seem basic, but I think there's lots of details in here that at least patients are getting wrong every day, and it really matters. It really matters what we call dementia. And so if you think about it this way, dementia is an umbrella term that corresponds to anything that can cause a dysfunction in everyday life related to cognition. So one or more cognitive domains like memory, visuospatial function, motor function, coordination, processing speed, language, any of those go down to a point where it's causing disability in everyday life, where you're not able to do your activities of daily living, like take care of yourself, or some of your independent activities like banking and driving and things like that. That's what we call dementia. And so that could be everything from Alzheimer's, which is the classic thing we think about that we're all worried about, but to things like depression or post-traumatic stress disorder, which can cause cognitive dysfunction to the point where it's disabling. And so dementia is an umbrella term. And the way I like to think about it is in two buckets under that umbrella. One is reversible causes of dementia. And so depression, post-traumatic stress disorder, while those are very difficult to treat, those are not neurodegenerative, progressively worsening diseases. Those are, to some extent, reversible. And so the cognitive dysfunction related to those conditions, as well as many others that we can talk about, can actually improve with treatment. Whereas the other bucket of dementias are the neurodegenerative, irreversible, progressive dementias, where neurons are dying progressively over a period of time when that condition starts. And those are, at this point, irreversible.
Yeah. And I think that leads us really well into how do we diagnose it, right? Because that then means that the dementia diagnosis must be a clinical diagnosis, right?
Yeah.
And if we're starting to think about, well, there's some things that are reversible versus some things that not, it's a kind of clinical presentation.
Yeah. No, it's a good point. I'll just say for clarity, the progressive or neurodegenerative causes, the classic one is Alzheimer's, dementia with Lewy body, Parkinson's related dementia, frontotemporal dementia, just to give you a sense of what that other bucket is. Going back to the reversibles and our approach to making a diagnosis, first we've got to rule out reversibles.
Right.
So big buckets there, vitamin deficiencies like vitamin B12, thiamine, folate, alcohol use and other substance use disorders that can affect cognition and cause disablement in everyday life. Things like sleep apnea and other sleep disruptions, mood and anxiety disorders that we've talked about already, hormone dysfunction, thyroid disorders, for example. These are under the classification of reversible. So we first look for all of those as a cause of an individual's cognitive difficulties. Maybe they have memory difficulties, vision difficulties, visuospatial, trying to navigate, getting lost. And so we look first for those. And let's say all of those checked out. We get some blood work, we take a good clinical history, we do a physical exam, we're looking at their medical records to understand what they've been through. If there's some looming other medical problem that's at hand, maybe they have hypertension and it's causing blood perfusion problems, and that's causing cognitive dysfunction. But with good treatment, that could reverse. Maybe it's diabetes, it's a cardiometabolic problem, and now that's causing a mismatch of energy and misuse and inefficient use of the brain. So that's causing cognitive dysfunction. We improve that, their cognition could improve. And so those are the reversibles. Those are some examples. It's obvious how you would test for some of those, and then how you would treat. In fact, I've had a patient recently come to me in the movie industry, and kind of the production. He said, "Look, I used to be able to build the set, take down the set, and do all of the legwork, no problem, easy. I remembered everything, remembered everyone's names, and suddenly, after I had some type of illness, maybe it was COVID, maybe it was flu, wasn't healthy enough to go to the doctor, I couldn't remember anything new, and so it would be anterograde amnesia. I would have conversations, I would have appointments coming up, I would have things I needed to do, things I was told to do, and I couldn't remember." And so I looked at his risk factor profile. I looked like what labs has he ever gotten, what checkups, what primary care visits. Turns out he had a diagnosis of prediabetes years ago, hadn't been to a physician in a long time, finally got back to a physician, got a bunch of labs, had diabetes, high cholesterol, high blood pressure, and a number of other things that potentially could be treated. And so I said, look, let's get aggressive about this. Use your primary care doctor as a jump-off point to quarterback everything. And he did everything, and his memory got way better. Yeah. The fact of the matter is, because of those risk factors, he had a stroke in this one part of the brain, in the thalamus, the medial dorsal thalamus, that knocked out part of his memory circuit for making new memories. Yeah. However, it was one side, the other side was still functioning, and with improvement in those risk factors, those reversible causes of, in this case, cardiometabolic dysfunction, he was able to improve his memory and get back to work.
Yeah, I think great story. And, also these modifiable risk factors that we talk about, they could be prodromal. And I think it's important to note that if you optimize treatment for these modifiable risk factors and there's no improvement, then potentially these things like psychological symptoms like depression could just be a prodrome of something.
Let's unpack that. So what do you mean by prodrome?
Well, we know psychological symptoms are, significantly associated with certain dementias. Right. And sometimes even they are the presenting symptom.
Exactly. I think that's where really we need to, kind of get clear on, because while psychological disorders, mental health disorders, can be a risk factor, which we'll talk about soon, they can also be part of the condition itself. That's right. Due to the mechanism of progressive degeneration that's occurring in the brain, that can cause an individual either to have emotional circuits be affected and their emotion and their coping and their capabilities change in that respect, and or they could be very aware of their difficulties, as is common in Alzheimer's, and that can cause some anxiety, some mood disturbance itself, and would be in that case a prodrome or kind of a foreshadow of another condition kind of looming and percolating.
Yeah, it's interesting to think about how far are we willing to extend the whole prodromal theory, right? When you're talking about diabetes, and you've heard of dementias now referred to like the type 3 diabetes. It's interesting to think about. What do you think?
Yeah, well, so it's a good question. I think we should table it for the risk factor conversation, because I think prodrome really is a sign that something's happening already but hasn't taken form in the typical presentation. And so the typical presentation, let's say, of the flu is runny nose, cough, and upper respiratory symptoms. But the prodrome to the flu is achiness. Achiness can be caused by working out the night before, having a bad night's sleep, eating something bad and getting inflamed. So the achiness is the atypical foreshadow, but due to the immune response for the infection that is yet to present in a typical fashion. So I think prodrome is the beginning of an illness, and has to do with the illness itself, rather than a risk factor that is in some way causative in either directly or indirectly of the condition itself. Yeah. And so when we talk about the risk factors, I think those are all way before prodrome and have to do with instigating the illness itself.
For the paper that we're going to talk about, they actually mention that they looked at depression. It was a risk factor for dementia. But in their paper, they recommended that moving forward, future studies look further out than what they looked at, right? Like looking at depression.
Within 3 years of a dementia diagnosis.
I thought it was 5. Yeah. Whatever. Multiple years out from the actual diagnosis.
Yeah. Well, in their study, within 3 years, it just was too close to make the call. Yeah. But looking further out, 10 years before. Yeah, totally.
Yeah. Okay. Let's keep it moving.
Yeah.
Yeah.
So we talked a little bit about kind of the reversible causes and going after a workup for cognitive symptoms in that way first, making sure that we're looking for these things that can be treated, that can off the bat improve symptoms. And it might take days, weeks, or months, but these are worth checking out. And I'll plug one of the reactions that we'll have to do at the end, the Bredesen method. The Bredesen method made its name off of a book of cases that found B12 deficiencies and other things that could be reversed with vitamin supplementation, for example, in this case, and said dementias are reversible. But that's not true. Dementias caused by reversible mechanisms, like vitamin deficiencies, are reversible.
Reversible dementias are reversible.
Yeah. Right. Yeah, but irreversible progressive neurodegenerative ones aren't yet reversible. There's no curative agent at this point.
I think, that's getting into understanding the nuances and the differences under this umbrella term of dementia, which, you helped us do between neurodegeneration and reversible.